Good afternoon, everybody, and welcome to a rather wet and dark March the 9th midweek COVID update. Hold on, let me come up. Right. Nothing too unexpected here. This is the same graph that I've been showing for the last couple of weeks. We are certainly well out of our fourth wave, and now we're in the interwave period, trying to get to these baseline interwave in terms of the epidemic curve, and just not quite getting there. But certainly we are officially out of our fourth wave. Number of cases still grumbling along at about 1,000 cases to 2,000 cases per day. Fortunately, no deaths reported over the last 24 hours. So a pretty kind of reasonable interwave kind of spectrum. The percentage of positivity of tests which are going to laboratories, we'd like it to be below 5%. So we're getting this about 7% at the moment of tests which go to laboratories which come back as positive. The Hatsola monitoring starting to come down a bit. So really kind of looking, we are at a pretty kind of low level at the moment. And globally, this is a similar kind of situation. We see in Europe and North America, Australia, so on, coming down quite markedly. In most countries, there are a couple of exceptions. I think I mentioned last week as well, Hong Kong is having quite a severe epidemic at the moment. And even a country like New Zealand is having quite extensive activity, viral activity, where they've been pretty free up to now with tight controls. But as these restrictions get lifted, so the number of cases proportionately increase. So we're now in our interwave period. And what do we do in our interwave period? And this is really what I wanted to discuss. I started it last week with regard to restrictions. Should we, and many people are advocating that now, because we're in such a quiet phase, because immunity is quite high, should we do away with restrictions? Can we afford to do away with restrictions? So I touched on it last week. I'll do it again. I'll touch on one or 2 points again now. Do we still need the same drive to vaccinate people, or can we rely on our natural immunity? I'll deal with that today. And then next week, I'll wind up talking about how we understand risk, because this is really where it is. Where do we peg our risk? Is the risk great? Can we afford to relax our vigilance, our restrictions, our precautions, and so on, in terms of where we are at the moment with the wave, the interwave period, and what the risk is going forward. So let me look at a couple of issues which I started with last week about restrictions, and particularly about masks. I think masks are really what most people want to kind of do away with. It's interesting because, I mean, it's really the kind of inconvenience of wearing a mask, more than really that it's affecting people's livelihood to the same extent as many of the other restrictions, of course, do. So let me just summarize where I think the majority, if not the consensus of scientific opinion is. And certainly in this country, this is the feeling, the 100% feeling amongst the advisory group scientists with regard to masks now in the interwave period. Outdoors, because the risk of transmission is very, very much lower, generally speaking, masks are not necessary. And I say generally, obviously one has to do a little bit of common sense. If there's an outdoor function with a high density of congregate individuals congregating together, there may be a situation where masks might still be necessary, even if outdoors. Outdoors, the risk is greatly reduced, but it's not zero. But generally speaking, outdoors, we can say that we don't really need to kind of impose a mask restriction. Situation is different in indoors. Indoors, we all will agree, when I say all in the advisory committee scientists, that masks are necessary. Masks are necessary. In some situations, masks may be impractical. For example, the restaurant situation, gyms, and those kind of situations which are indoors. But then there needs to be additional precautions. First of all, there needs to be very good ventilation, cross ventilation between doors and windows to do as kind of a pseudo outdoor kind of atmosphere. Physical distancing becomes very important if masks aren't worn, for example, in that restaurant situation, the gym situation, and so on. And some of us or some people are advocating that in this situation where it's indoors and masks are impractical, that there should be a vaccine mandate. Now, vaccine, of course, is not 100% protective, but at least this is another precaution in a situation, because masks should be worn in the indoor situation, at least have a vaccine mandate as an additional precaution to reduce the risk. I will stick my neck out a bit. In the shul situation, the synagogue shul situation, I really don't think it is impractical to not wear masks. I think the shul situation is a particularly risky situation, not only indoors. People do, by definition, it's a congregate setting. Voices are raised and singing, in davening and so on, generating aerosols and droplets. And I think that the shul situation, masks should still, at the moment, be required. There's been a plethora of scientific publications, observations, investigations demonstrating the value of masks in the school situation. These are very recent publications, as you can see, from the Center for Disease Control in their official publication, the Morbidity and Mortality Weekly Report. And they've shown that in schools, there's a significant difference in those schools which have a mask requirement and those schools which don't have a mask requirement. And similarly, this study, it's done in California over close to a year, over last year, again showing the very significant advantage of face masks in the indoor public setting. This is an interesting one, which is actually, it's a modeling exercise where they've actually calculated what would be saved if masks were still to be used, or the other way around, if there's no mask usage, between now and when one reaches the target vaccination coverage level. And they're putting it between 70 and 90%. This comes from the United States. It was published very recently in the Lancet, very prestigious Lancet. And they would calculate that if there's no mask usage between now and the situation, they're saying potentially July of this year, between now and then, if there's no mask usage, what it would cost in terms of hospitalization, close on 300 hospitalizations per 100,000 persons, as against 122.5. Similarly with direct medical costs, the cost of no mask wearing usage, comparing if mask usage is achieved until target vaccination level is reached, and productivity losses and so on. So again, emphasizing that even now, in an interwave period of low transmission, there still is even a cost benefit of wearing a mask in addition to the health benefit, as I mentioned earlier. So let me do a couple of words about the issue about vaccination, because there are some people who are saying, really in the kind of vaccine hesitant group, who's saying, why now such a low level? The low level is due to natural immunity. Why have this extensive drive for people to be vaccinated? I think some of these graphs, speak for themselves. Okay, this is between October and November in the United States, the benefits of a booster dose. This is the booster dose as well as the vaccine. Unvaccinated, the weekly average deaths, the worst case scenario of COVID infection. Unvaccinated, 7.8 per 100,000 average death, compared to vaccinated with no booster, 0.6, with a booster, 0.1 per 100,000. You see the vast difference of protection being vaccinated. Again, showing in this graph, unvaccinated as against vaccinated without a booster and vaccinating with a booster. And again, even in our South African data, as you can see over here, the There are currently, and this is now, today, 2,370 people in hospital with COVID, adults that is. The number not vaccinated, close on 3/4, 1,767. Those in hospital who are fully vaccinated, just under 1/4 of the total hospitalization are people that have been fully vaccinated and yet are still in hospital. But of course, within this figure are also people who've got underlying illnesses, underlying comorbidities. So again, graphically demonstrating how unvaccinated versus vaccinated, the green being the vaccinated and the red being unvaccinated. And unfortunately, just to again emphasize that in terms of our vaccination coverage, we really are we're under 50% of those of the adult population who've had only at least one dose. In other words, more than 50% of the population have not even had one dose of vaccine. We look at the booster, that's the third dose of Pfizer. Only 3.44% of those who had their first doses have bothered to come back for a booster dose. And unfortunately, I keep on showing these graphs, but I think this is quite important. The high-risk group, the 60-plus age group, the older age group, 68.24% have had one vaccine at least, but fully vaccinated, that's with 2 doses, not the booster, 2 doses, it's 62.1. In other words, 38% of our elderly population have not been fully vaccinated as yet. And you kind of compare this to the situation in the United Kingdom in terms of 3 doses and various age groups, and compare that to where we are. So just to round up, I think we all know this. What are the benefits of vaccination? The individual benefits: preventing illness, preventing severe illness, preventing deaths, preventing long COVID. Also the benefit to the country, because the infectiousness is reduced. And then also the benefit to the economy as well. I won't go through all of these. They're pretty kind of self-explanatory. So vaccination has tremendous benefit, individual benefit, country benefit, and economic benefits. And just, I get often asked by many people, we know that the vaccine is pretty effective. It's very effective in preventing severe disease. It's pretty effective in preventing mild disease. But what is the efficacy in reducing infectiousness? And again, there have been these are a sample of many publications where they've demonstrated that vaccination reduces the ability of an infected person to pass on the virus to other individuals. And this is because the amount of virus in the throat gets markedly reduced. Also, the duration of infectiousness, where there is breakthrough infection, people do get infection despite being vaccinated, that is also drastically reduced. So all these factors contribute to reducing the amount of virus in the population, as well as protecting the individual. So next week, I'm going to talk about putting this all together, where we are at the moment in terms of the low transmission interwave period. What is the risk? How do we understand this? What are the risks of the next wave? When is the next wave going to be? The next variant and other risks, and how we kind of understand this risk going forward. Next week will actually be my last COVID update for a while. I think now with this period of low activity, there's not much point repeating all those graphs again. So we'll take a bit of a break. I'll be traveling, and we'll probably come back again after Passover. So there will be a update next week. We'll look at understanding risk, and then there will be a break for quite a few weeks, probably till after Pesach. So let me come to a couple of the questions which have come in. All right, there was a question from a viewer looking at the mortality rate, in other words, the most severe in children with Omicron. Now, certainly Omicron, we did note, and I've mentioned in one of our sessions before, that it does, relatively speaking, seem to affect children and young adults more severely than previous variants. So, for example, if we look at the infection rate amongst less than 18-year-olds, that's adolescents and children, with a beta variant, remember that was the second wave, 3.9% of the infections were in children, adolescents less than 18 years. The Delta was 3.5%. In contrast to Omicron, 17.7% of the infections were in people under the age of 18. So certainly the infection rate was certainly higher. In terms of hospital admissions, it was in children, again, 49% higher than the Delta wave. That's in very young children under the age of 4. If we look at older children, 4 to 18 years, 25% higher than the previous in the third wave due to Delta. So certainly children have been affected more, and hospital admissions higher, infection rate higher. Unfortunately, there haven't yet been published any mortality data, so I can't answer that question at the moment. Mortality rate with Omicron, even in children, must be very, very low. I'd guess it's probably a fraction of a percent, very, very low. But again, I say there hasn't been published data on that as yet. The same person asked for the value of supplements such as zinc and vitamin D and vitamin C, melatonin, probiotics, and so on. You know, these supplements have been evaluated many times in clinical trials, and none of these supplements, the zincs, the vitamin Ds, and vitamin Cs, have been shown to have any therapeutic benefit, either as a prevention or early treatment or late treatment. I know they are regularly given as treatment, and certainly they probably don't do any harm in the doses that they are given, but there hasn't really been shown scientifically to be any benefit in these treatments. Then there was a second question from somebody, I presume it's a timeshare, and they are going to a timeshare unit where the previous occupants had COVID. And, you know, I have mentioned also on a few occasions that surfaces, tables and chairs and so on, and food really don't pose any significant risk in transmitting COVID. Now, obviously, if we're looking at a high-risk situation, a hospital ward, if somebody has been in a hospital ward with COVID, where they are excreting very high levels of the virus into the aerosols and so on, those rooms do need to be fogged. They do need to be cleaned very, very thoroughly, what they call deep cleaning with antiseptics and so on. But that really does not apply to the situation outside hospitals. It really poses almost no risk. And if there's a period of even a day or two between somebody that has had COVID in the room, somebody coming into COVID, somebody coming into that room, the risk of COVID transmission is negligible. So I really would not worry about at all of going into a room where somebody has had COVID, particularly if there has to be a day or two interval between them. And then there has the last question. There has been a leaked report. You've got a lot of media publicity. In fact, I'm going on to Zoom Africa to talk about it, and it's 1:15 from Pfizer. Now, what happens at Pfizer, when they apply for their licensing for registration, they have to list all the reported side effects, or what you call adverse effects, the side effects of the vaccine, to the regulatory authority, in this case, the FDA, the Food and Drug Administration of the United States. Now, this is normally kept reasonably confidential. I say reasonably confidential. Obviously, quite a wide range of experts need to have access to this, but normally it's not released to the public. And this was either leaked to the public or it was leaked to the employees of Pfizer. The whole list, 1,291 various adverse events. Now, you know, if you get a Panado or you get any medication, you get what's called the package insert, the little piece of paper, which is a thin piece of paper, which is folded up inside the box. there's a long, long list of everything from indigestion, dyspepsia, being unable to sleep, having nightmares, and all this kind of thing is listed. And by law, they have to list everything which has been reported. Some of these things are completely, of course, unrelated. They just happen to be at the same time that the vaccine is administered. So, in fact, the CDC came out with a response to this, and they said of the 1,291 conditions which were listed, and some of them are quite bizarre, 92% are mild. Now, obviously, vaccines are not totally innocuous. Um, if vaccines were innocuous as a cheese sandwich, they'd probably be as effective as a cheese sandwich. So there will be some side effects. And we know that many people do get a tender arm. They might have lymph, the glands under the armpit might swell. They might have a bit of a rash around there. They might feel a bit of color the next day, but feeling fluey or maybe a bit of a headache. That is your kind of sensitivity to these chemical mediators, which are part of the immune response, being liberated into your bloodstream. You can treat it with a Panado or aspirin, whatever it is, to make you feel more comfortable. So those side effects are reasonably common, and they are expected, and you need to counsel people that are being vaccinated to expect that. These more severe side effects are very, very rare. The CDC, where they commented on this Pfizer thing, they said less than 1% of what is listed require medical care, and that's very uncommon. Even the heart inflammation, what you call the myocarditis, I think I've spoken about it before, the vast majority of those are treated at home. They're mild, they have no after effects. So with all these things, you have to weigh up what you are preventing, and you're preventing COVID. And these 1,291 side effects of the vaccine are probably 10 to 50 to 100 times more common with COVID disease itself. We look at the myocarditis, you're looking at the blood clots. All of these are vastly more common than the infection which the vaccine prevents. So vaccines are really almost innocuous. These side effects are very rare. These serious side effects are very rare, a handful per million doses. And the minor side effects are more common, of course, but they are really minor, they're fairly trivial, and they can be treated and so on. So I'll say farewell now, and keep well, and we'll see you next week. All the best. Bye.